Hi everybody, my name is Andrew Goldsmith. I'm one of the ultrasound fellows here at Mass General Hospital. I'm here today with Dr. Andrew Leteplo,
Hi, everybody. Thanks for joining us.
and we're here to tell you a case about a patient whose back went out. So let's get to the case. A 27-year-old female presents to us with a known L5-S1 disc herniation. She's coming to us with acute worsening of gluteal pain that radiates down the back of her right leg. Her vital signs are otherwise unremarkable, and on exam, she has limited strength in that right leg due to pain. Her straight leg test is positive, and she's otherwise neurovascularly intact. When you look back in her chart, you review her MRI, and you see an obvious L5-S1 herniation. The patient's already taking oxycodone, cyclobenzapine, ibuprofen, and Tylenol without effect. She already has a follow-up appointment with chronic pain and neurosurgery, and yet she's still unable to ambulate due to her pain. What would you do next?
Well, this is a tough one because I think we have a good answer, so we don't need to do much of a diagnostic workup. But the patient can't walk, and so it's hard to send her home. The goal here is to manage her pain. She's already taking a lot of medications, and we don't have too many options. We could try a lidocaine patch. We could admit her to the observation unit, hope that physical therapy can help her get more ambulatory, but she might need to be admitted overnight if she can't walk.
Well, this patient has obvious sciatic radiculopathy. So what about if we did a transgluteal nerve block?
A what?
A transgluteal sciatic nerve block. Let me tell you a little bit more about it. So the sciatic nerve, as we know, comes out the posterior leg all the way down to the bottom of the leg. And as you can see on the right, the distribution is almost of the entire leg for sensation innervation. So basically, as you can see, you try feeling for the greater trochanter, as you can see on the picture on the left, and you're going all the way to the ischial tuberosity. Now, a cross-sectional ultrasound picture you can see on the right, as you can see the greater trochanter, you can see medially the ischial tuberosity, and then anteriorly you see the gluteus maximus, and then finally in the middle you're going to see this huge hyperechoic structure, and that's the sciatic nerve itself.
This bright white thing right here?
Yes, the bright white thing right in the middle of your screen. So the way to approach this block is you're going to use a curvilinear probe, and you're going to grab two anesthetic solutions, well, really one plus a steroid. You're going to use 0.5% bupivacaine, and you're going to use approximately 10 to 15 mLs of it, which equals approximately 50 to 75 milligrams. In addition, you're going to also grab dexamethasone, approximately 10 milligrams, which equals about 2 mLs.
Why do you use the dexamethasone?
Well, the dexamethasone has been shown in other studies to actually prolong the half-life of your bupivacaine, thereby increasing your length of pain relief.
Got it.
So before we injected, we actually consented the patient. We, of course, went through all the risks associated with this, including infection, bleeding, nerve injury, and finally, LAS syndrome as well. And as you can see previously, we are way under the 2 milligrams per kilogram if you assume that most patients are around 75 kilograms.
Right.
The only risk associated that's particular to this exact block is actually potentially a temporary foot drop. However, I've never seen that before. Have you, Andrew?
No.
So when preparing for this block, you're actually going to have your ultrasound machine opposite of you. It's going to be sterile with a tegaderm over the probe, and you're going to actually use your needle tip approximately 70 degrees going in at your sciatic nerve.
So pretty steep.
Pretty steep. So here's a cross-sectional pictures of your actual sciatic nerve. And as you can see, the description of your layout is in A, and as we keep going through from B to D, you see your cross-sectional picture with your sciatic nerve right in the middle. In C, you can see your needle tip right here coming under that fascial layer of your gluteus maximus directed at that sciatic nerve. And finally, in D, you can see the lidocaine injection in small aliquots right under that fascial layer, right next to your sciatic nerve. Here's a nice clip showing your needle tip approaching that fascial layer right here, about to go right through that fascial layer. And here, you can see your needle going right here and finally injecting some lidocaine right on top of that sciatic nerve. So back to the patient. About 20 minutes after performing the procedure, her pain score went from 10 to 2, and by 1 hour, she was ambulatory walking around the emergency department. We actually called her back to see how she was doing, and 3 days later, she still had a 90% reduction of her pain.
That's amazing. The last guy I did this in, same thing, could not walk at all. We did the block, and within an hour, he was literally doing Pilates in the room. I felt like one of those healers that just takes these people that can't walk and just makes them dance.
So, transgluteal nerve blocks, they can reduce or eliminate your pain quickly, safely, and efficiently. The key here is to actually get your needle right under that fascial layer and inject slowly. So, what's next? Well, maybe this block could actually reduce patients' length of stay. Potentially, it could decrease admissions for pain control. And if those two are accomplished, the patient will definitely feel satisfied.
It's got a huge role. We just don't know exactly what it is. But if you're interested in helping out your patients with acute low back pain that's probably from sciatica, give this nerve block a try.
Thank you guys for listening, and we look forward to hearing from you. Please hit us up on Twitter.
Thanks. Keep scanning.